Thank you, Sean. So welcome everybody to this uh, fascinating webinar. I hope it will be. So first of all, this is a welcome message from the president of ICUS, which, as you know, is called International Contrast Ultrasound Society. Dr. Professor Feinstein and Professor Wilson, who on behalf of ICUS, they are very pleased to extend a warm welcome to all of you in today's webinar. And they also thank all those who have planned today's program, Sean behind the scene, and also express appreciation to Northwest Imaging Forum, of which Sean is a part, of course, who are the providers of exclusive CME for ICUS for the support of the educational program. And so moving on, what is ICUS? As I've said, it's actually International Contrast Ultrasound Society, and it has members in 60 countries. It's truly global. Physicians, sonographers, nurses, scientists, industry, and patients together, and catering to all aspects of medicine, actually radiology, cardiology, hepatology, vascular and GI medicine, and more. ICUS is free, so join now because it's free. You don't have to pay any money. It provides free webinars, CME credits, free website. It's got a mobile app, and also it has news monitor where the latest bubble news and trends, you can see them. And it is in English. It will be in English, Mandarin, and also other translations are available. So the commitment of ICUS is really commitment to contrast enhanced ultrasound, ultrasound, which is an essential tool for modern ultrasound labs throughout the world for more than 20 years. The thing about CUS is it is safe, portable, ionizing radiation free, produces high resolution images and in real time of the cardiovascular system, the major blood vessels, the organs like liver, spleen, kidney, and tumor perfusion. And it reduces quite often downstream testing. Once you've done the examination with contrast enhanced ultrasound, you can reduce further testing because you get more or less a definitive answer, as you will see in this program. It improves, obviously, the hospital workflows and speeds access to diagnosis and therapy. So our commitment to free CCUS education is very much there. So for all, for physicians, sonographers, nurses, and other ultrasound professionals. And all live webinars are recorded, so you have availability of all those recorded webinars. And again, they're all free of charge. And then, of course, you have the case of the day presentation through Instagram, and it's a very popular medium through which you can actually, access case of the day. And then there is a sonographer training resource hub, which you can take advantage of. And then you can also download ICUS Connect, which will, take you to various aspects of education, like testing, test yourself for case on the day, finding protocols, product labels, etc. Sonographer Training Hub. And then we have the CEUS News Monitor, where it flashes up all the recent advances in CUS. And then, of course, you have this advantage of, guidelines all over the world published by international societies and how to set up a lab, CUS lab, and code for reimbursement. As I've talked about, case of the day challenges, bubble TV interviews, and bubble blogs. So I would encourage all of you to join ICUS. As you can see, it's free and provides so many functionalities that is highly educative. And finally, of course, you know, it's it is with sincere appreciation to all the sponsors for the generous support of ICUS and the leadership of the ultrasound field. So Bracco and Lantheus, G Healthcare, Canon, Philips, Siemens Healthcare, Denton's, Roman Studios, Northwest Imaging Forums, Custom Media, Live Media. Thank you for providing sponsorship, all of you. So now we'll move on to today's agenda. Uh, so we will. So the first speaker will be myself, followed by Professor Matthias. So without much ado, I will get started. So first of all, I'll stop sharing the screen now, and then okay. So so today's topic is amazing contrast echo cases. So they are all cases where it has made a difference in managing patients. So let's start off with the first case. Sorry, let me skip all this because you've seen this all the time. We need to go to more, yeah, there we are. So let's talk about this case, this patient, 63-year-old lady with angina, has chronic total occlusion of the right coronary artery and underwent retrograde PCI, meaning the percutaneous intervention was done through LED septal vessels because they couldn't go through the occlusion to open up this artery. So when doing so, as you can see here, they went down the septal vessels, but they failed actually. And so they decided to go down the right coronary artery, antegrade flow, which they managed to do. As you can see, the artery is now open, and you can clearly see the flow down the right coronary artery. But they noticed that there is some staining in the of the myocardium here. I don't know whether you can see through my pointer that there is a sort of a staining, but they didn't think very much of it, except that okay, to keep an eye on what's going on. Now the patient was okay, the patient was fine, but few hours later, the patient complained of excruciating chest pain. So an echocardiogram was done. So this is the echo, and you can see the images are a bit difficult. The patient was in excruciating pain, and you can see the left ventricle on the right side and the right ventricle. But within the right ventricular chamber, there appears to be some sort of a mass which was not there before. So the question is, what is this mass that has suddenly appeared, right? So now contrast was given, and now you can see that with the contrast, again, you can see the left ventricle actually doesn't have any wall motion abnormality. You can see the right ventricle, but what you can clearly see that attached to the inferior interventricular septum is a mass which is not enhancing. It is totally black while there's a lot of blood flow around it. And we made a diagnosis of hematoma. And so with this diagnosis, the treatment really is to see what happens to this hematoma as time goes, and the patient's pain management is the other thing. But meantime, to get a better idea of where this hematoma is actually coming from, we can see it's clearly coming from the septum. But in relation to the right coronary artery, where is it situated? CMR was first done, and you can see on the bottom left that the CMR, there's the right coronary artery, and you can see adjacent to the right coronary artery is this mass within the right ventricle. And also you can see with the CT also is very nicely shown this mass here. So clearly this patient does have a hematoma as pointed out by a contrast echocardiography, and subsequently the mass gradually uh, uh, diminished with time. By 10 months, it's gone. So as you can see, this case clearly illustrates the benefit of doing contrast echo at the bedside and coming to a diagnosis straight away, and therefore managing accordingly. Now, this is another patient, 55-year-old man, presented with chest pain and shortness of breath, known to have mitral valve prolapse. And the patient has it here, nothing extraordinary. The patient has mitral valve prolapse, and the LV is contracting well. And this is the a color flow, and you can see there's a lot of MR. Now, the patient didn't have that amount of MR before as a result of mitral valve prolapse. This is quite a lot of MR that has been noticed, but the patient just has mitral valve prolapse. Now, we are not sure what's going on with the valve actually, but there seems to be something within the color flow. You can see there's something, some black areas there, but it's not very clear what's going on. So we gave contrast. Actually, the patient actually underwent a GOE at that time. That's right. And you can see clearly the mitral valve prolapse. And you can see even here, the mitral valve prolapse, but nothing more than that. So we gave contrast here. And now you can clearly see what's going on. You can see a cyst-like structure within the left ventricle, but attached to the anterior mitral leaflet. And that is disturbing the closure of the valve, giving rise to severe mitral regurgitation. And this patient then underwent intervention, and you can see that this mass is attached to the anterior mitral leaflet as shown on the contrast echo. And this patient, you can see this dark colored cyst here. This is a blood cyst that has become big. So a blood cyst is something that can be very small and can actually suddenly enlarge to cause the disruption of the surrounding structure, and they are related. They affect the endocardium and therefore the valve leaflets. So this is an example of that. So moving on, another case. So this is an 81-year-old man who had a mitral valve repair in 2005, but developed worsening MR and then underwent transapical mitral valve replacement with a 26 millimeter Edwards Sapiens tissue valve in 2017. But 2 months later, the patient came back with left pleural effusion, which was drained. 8 weeks later, he noted a gradually enlarging painful soft tissue swelling in the left chest. Now, contrast CT was done, which showed, a hematoma-like structure extending to the chest wall, but no active contrast extravasation was demonstrated. CMR showed a collection around the LV apex, mostly the pericardium, but some extending into the intercostal space and chest wall. But it was not clear what is this swelling about. So we did an echo, and you can see on the left the echocardiogram is showing, a cyst-like structure, or rather echo-free space outside the left ventricle, and that is what has been identified by CMR and CT. As you can see, we put on the color flow, but it's very difficult to say what's going on. It could be some intercostal vessels you can see there, but really it doesn't give us much more than what we already know about this patient. However, we said, okay, let's give some contrast and see where is this contrast going. So we injected contrast. So this is an example of that. You can see this is a 4-chamber view. Contrast has been injected, but watch what happens to this space here. You will find microbubbles appearing there. You can see 1, 2, 3, 4, gradually it is filling up, and then it is stopping, right? So this is an extravasation from the left ventricle through a small hole in the LV cavity, and not LV cavity, LVT muscle. Because remember, transmyocardial mitral valve was performed, and there was a residue there, and that has given rise to this accumulation of blood within this space. And you can also see again, another, as you can see how the bubbles are traveling there, right? Very nicely. And if you see another image, now this is a flash replenishment image. You can see now it's flash coming up and all the bubbles are gone. And now you can see it's appearing again within this mass here. So we said, okay, this is a small leak through the left ventricle. All we need to do is to do a compression bandage and see what happens. And that's what was done. Again, we published this case actually. That's why you see all these figures there. And the patient was managed conservatively, followed up with echocardiogram, which showed a reduction in bubble extravasation and resolving hematoma. So another example how contrast echo came to the rescue of the patient had CT, the patient had MRI, but they didn't know what is the cause of this structure outside the left ventricle. So now we come to another patient who's 72-year-old who had metastatic colonic cancer with vasculitis, cardiomegaly on chest X-ray, no cardiac symptoms. So they were thinking of, uh, you know, intervening on this patient at some point, and they wanted an echo to be done to see, first of all, to find out why is this cardiomegaly, and also to see whether one can, the heart, what is the heart function. So now if you look at the screen here, so these are a series of images, right? Parasternal view, color flow, nothing much. But there in the four-chamber view, you can see there is something there, an echo-free space outside the right ventricle. And the color flow is actually none the wiser. You don't see exactly what's going on. So contrast was again given. Now here you can see, something is happening here. We are not sure what is this thing sticking out there, but you can see clearly with contrast, there is a rupture of the apical part of the left ventricle with contrast flowing into the pseudo aneurysm. So now what was done to this patient? Now it's clear that this pseudo aneurysm has been there for a long, long time because the patient never had any symptoms. So the patient doesn't recollect any symptom of chest pain, etc. And also it was discovered that the patient has now grade 4 metastatic cancer, which is spread all over. And actually nobody is going to, the patient is only for palliative care. And with the stable false aneurysm, nothing was ultimately done. But we at least know what the diagnosis was in this patient. So we come to another patient now, 74-year-old male with past history of treated breast cancer, presented with heart failure. Now, echo showed this. You can see that both the atria are dilated. There is a mass in the left ventricle, apical mass. Now, what is the differential diagnosis of this mass? So the differential diagnosis is obviously we should think of tumor first because the patient had breast cancer, whether it is benign or malignant, a thrombus, apical hypertrophic cardiomyopathy, or is it eosinophilic infiltration? Now, the first thing that we did was to see whether that mass is muscle or not. So what we did is we did a stand-alone strain imaging. This red is placed on the muscle, and you can see there is absolutely no change in the strain value. It's a flat strain. So meaning it's a dead area that we are looking at, right? So it is not apical hypertrophic cardiomyopathy. It could be a thrombus, it could be apical infiltration, or rather eosinophilic infiltration, or a tumor. So now we gave contrast, and now look at this, we gave contrast. Now look at the mechanical index, it's 0.24. But even with this, you can see microbubbles within this mass. So clearly it is a mass which is seemingly vascular, but in order to be sure, we went down to low mechanical index imaging, but now here you can see the amount of vascularity that this mass has. So clearly this patient has got a malignant vascular tumor in the LV, which is a metastasis from the breast cancer. And if it had been a tumor, if it had been a thrombus, this is how it would have looked, totally black, no uptake of contrast at all. And you can see the distinction between a vascular tumor and a thrombus. So now coming on to another patient, a 66-year-old female with chest pain radiating to the back and suspected aortic pathology. The patient had previous acute myocardial infarction. So the patient had a CT of the aorta, and the CT showed a mass outside this aortic wall here, right? And they said it's either an inflammatory mass or a tumor. So this needs to be biopsied to know exactly what it is. But the patient was also sent for echocardiography because the patient had previous MI. The question is what is the LV function, etc. So the patient had an echo done. The echo showed wall motion abnormality, but old. But because the patient came for echocardiogram, we always do suprasternal views. So we did suprasternal view, and that's what we saw. You can see this arch. You can see just at the junction of the descending thoracic aorta and the arch is something protruding outside the aorta, right? The same thing what CT has noticed. So fine, it is something that CT has noticed, probably a mass that needs a biopsy. And this is the, color flow, and you can see nothing is going inside. So it looks like a separate mass there. But we were a bit suspicious. We said, okay, let's give some contrast and see what is the origin of this mass. Now, this is the contrast. Now you can very nicely see that the free wall of the aorta had ruptured, and the contrast is now going into this false aneurysm. So probably there's a thrombus there, false aneurysm. And so this is an urgent case where biopsy would have killed this patient actually by rupturing it further. So this patient was treated accordingly, taken to the theater for aneurysmectomy. And you can see how so this is again, so repeat, CT of the aorta following contrast echo. Now the CT did pick up this, abnormality, which they agreed that it is actually a ruptured aorta. And essentially, this patient then, you can see if we had left it to the CT diagnosis, then there would have been a catastrophe. So contrast really saved the patient's life in this particular instance. So now let's move on to another case. Now, this is a patient during the COVID times, active COVID. The patient presented with pulmonary embolism, and the patient had been treated with, anticoagulation, but the anticoagulation was stopped subsequently. The patient seemed to be better, and an echo was done to look at the heart function. And now, when we did the echo, we found something in the right ventricle. So the question is, what is it? Is it a thrombus? Is it just, a trabecule, folded trabecule there, wrapped into like a mass? So we did contrast here, low power imaging to look at perfusion of that mass. And now you can see the mass very clearly here, but you can see the mass is not perfusing at all. It is black. And because of the history of thromboembolism, we said that it is a thrombus which hasn't gone away. So you must restart the anticoagulation and continue that. And so the anticoagulation was continued, and we repeated the echo. And now you can see on the right, there's no longer any mass visible at all. So again, contrast helped in reinstating the anticoagulation, but now that was early days during COVID. At that time, anticoagulation was not given routinely, but subsequently, anticoagulation has been given routinely. But this was before that. So at that time, we changed the management of the patient, and this is actually data from a series that we did using ultrasound contrast agent. And you can see that change in anticoagulation was instituted as a result of contrast in about 15% of the patients. Change in other medication was also happened when we detected LV dysfunction, etc. And overall medication change had occurred in another 20% cases, and change in investigation occurred. So overall change in management in terms of investigation, medication, anticoagulation, etc., occurred because we used contrast in patients where we were not clear what's going on. And this certainly highlights the value of contrast echocardiography. So we come on to another case. I think it's just nearly half an hour, but I've got 10 more minutes. Another case is a 72 years old, post cardiac surgery, had CABG and AVR. Patient developed hypotension. So we were called urgently in the critical care to assess LV and RV and the valve. So now this is the echo. Now look at the quality of the echo. I mean, we can hardly make out anything what's going on here, right? Absolutely nothing. LV, we're not sure. RV, we're not sure. Valves, we are not sure. But we did get some valve data by doing Dopplers, and the valve was fine. The hemodynamics were okay. But then we injected contrast to see what's going on. So contrast was injected. Now you can see that the LV function is not entirely normal. Ejection fraction is reduced, but it is not unexpected following aortic valve replacement and immediate post-surgery. But what is striking is some echo-free space outside the right ventricle, and this space is actually compressing the right ventricle. And we immediately shouted out, it's likely to be a big hematoma pressing on the right ventricle and preventing and lowering the cardiac output on the right side, and therefore generally the patient is hypotensive. And the surgeons immediately, it was in the middle of the night, this was done. And the surgeons immediately went into the chest, and the patient had a CT immediately after also, and you can see that big mass there, compressing the right ventricle. And this is what they found, evacuation of mediastinal hematoma. Actually, what they found is hematoma overlying right ventricle, evacuated and pericardial effusion, and the patient subsequently, the blood pressure resolved, and the patient was fine after that. So again, you can see how use of contrast at the bedside in the middle of the night gave us the answer that otherwise we wouldn't be able to decipher. So I think I would like to close this. So since we are talking about the vascular part of it also, which I showed you a case of the aorta, but very quickly we do a lot of carotid ultrasound, and you see we look at plaques and all that. But we also can now look at intraplaque neurorevascularization. And Steve Feinstein has started this, concept, and it has really shown that it does make a difference in how we can manage patient. So, so you can see here. So now intraplaque neurorevascularization did show that it can lead to events, meaning rupture of the plaque and stroke and all that, but even myocardial infarction, a plaque in the carotid artery, which is neorevascularized, could also suggest plaque in the coronary tree, which could also be vulnerable. So with contrast, we can look at the intima media very clearly. We can look at the plaque very clearly. And furthermore, we can look within the plaque, and you can see microbubbles, traveling within the plaque. And this is another one showing the plaques, the microbubbles within the plaque. And this is an example of neorevascularization. And another example of neurorevascularization, you can see the plaque, but here the neurorevascularization is not that much compared to what I just showed you before. You can see the vasa vasorum there very well. And in fact, we did a study where we looked at plaque neurorevascularization in human carotid atherosclerosis related to prior neck radiotherapy. And we showed that those with who had radiotherapy, the site of the radiotherapy not only had increased plaques, but large plaques with neorevascularization, and that could probably be the reason for increased stroke in these patients who have neck radiotherapy. It's not only the fact that they have plaques, but they have extensive neorevascularization, and that is what is causing the stroke. So with this, I would like to end my talk, and I would like to invite Professor Matthias to show his cases from South America. Over to you, Wilson. Sorry, I'll stop sharing now.
Thank you very much, Roxy. I'd like to thank my colleagues and friends from ICUS and all of the participants. It's an honor being here. I'm gonna share my screen. Just a second. Okay. So echocardiography has come a long way since the MO days to the 2D Doppler and color flow, stress echo, and strain 3D. And now we have the microbubbles, the contrast enhancing agents that helps us in enhancing the image quality as well as gives us a very beautiful image of myocardial perfusion as well. This is my conflict of interest statement. So we just have some sponsorship from our NIH agency that's called FAPESP and from Lantheus Medical Imaging. Well, I divided my presentation on how to use the ultrasound enhanced agents, and then we are going to talk a little bit, showing some cases of Doppler endocardial border definition enhancement, myocardial perfusion in coronary artery disease, and then we are going to look at special populations and some different cases. And I will end with one emerging application of ultrasound enhancing agents. So just as a general rule, there are several ultrasound enhancing agents in the markets, but in general, you inject the amount of 0.5 to 1 ml every time. I will specify it a little further. We have to use a very low mechanical index to have a good image from perfusion and to look at as well at the endocardial border delineation. And we must keep the ultrasound focus very deep. Usually, if you are in the apical view, you should keep it below the mitral annulus. Once you inject the bubble, first you see the passage through the right ventricle once you inject a bolus. And after 3 or 4 seconds, it reaches the left ventricle, and then you see the nice left ventricular opacification and myocardial opacification, as you see in this case. So depending on the contrast and agent that you are using, you have like maybe 1 to 3 minutes to acquire a good set of images. And then you should repeat the bolus again. We should take care of few things while using ultrasound enhancing agents. First of all, if you inject too little contrast, or if your mechanical index is high, you get this swirling pattern. That means that you are destroying the bubbles, especially close to the apex. On the other hand, if you inject too much, even if you have the appropriate mechanical index, you have this acoustic shadowing. To get rid of the acoustic shadowing, you just wait a little bit, maybe 20, 30 seconds, and it goes away, and then you can acquire the images. But to get rid of the swirling effect, you have to adjust the mechanical index to 0.2 to 0.3 at most, and maybe you have to also increase the volume of contrast injected. The image we want in the end of the day is like this one on the top. So you have a complete left ventricular opacification with a very clear endocardial border delineation. So that's the image that we want in the end of the day. If you are using Lumason or Sonoview, you inject from 0.5 to 1 ml from the pure contrast agent, and followed by a bolus of 5 to 10 cc's that has to be performed within 5 seconds. If you are using Definity, you should dilute the 1.3 solution to a 50 ml into a 50 ml syringe and inject 0.5 to 1 ml bolus. And if you are using Opsom, you should inject undiluted solution of 0.3 to 0.5 ml each time, followed as well as follow a bolus of 3 to 5 ml, at most 5 seconds later. So let's talk a little bit on endocardial border definition. This is a 71-year-old male with hypertension, and he's a smoker. He's got effort chest pain. This is his transthoracic echocardiogram. This is the parasternal long axis view, shows normal left ventricular function and some calcified aortic valve. And you also can see the calcified aortic valve in the apical long axis view. The problem is you don't get a good continuous wave Doppler signal, and we only got 24 millimeters of mercury peak gradient with this image, and that's the quality of the continuous wave Doppler that we got at this point. So once we injected 0.2, it just says very small dose. You don't want to inject the same dosage that you use for left ventricular opacification, that in the case of Sonovil would be 1 cc, 1 ml. So we just injected 0.2 ml of pure Sonovil, and we just saw an increased signal in the apical views that's close to 4 meters of velocity. And then we changed it to another view, a suprasternal notch view, where we got a very nice envelope that is 4.5 meters, which gave us a gradient of 87 millimeters of mercury. So the ultrasound enhancing agents, in this case, was crucial to define the severity of the aortic stenosis. And in my practice, I see that that's probably one of the situations, if you don't use a ultrasound enhancing agent, you will underestimate the severity of aortic stenosis in a significant number of cases. So in this case, it was very important. This is our case number 2. Guys, just 1 second. Just want to see one thing. Sorry about that. Okay, no. I was worried that I was in the wrong presentation. Sorry about that. This is another case that's a male patient with enlarged left ventricle in the X-ray, and the electrocardiogram shows these negative asymmetric T waves in the precordial leads. And this is his transthoracic echocardiogram, apical 4-chamber view. We see that the left ventricular function appears normal, but we can't clearly see the endocardial borders. And once we inject contrast, we see quite nicely that we see the endocardial borders quite well, and it becomes apparent very significant apical hypertrophy in this patient that actually had apical cardiomyopathy. And this is another female patient that 52-year-old with a head trauma. She was intubated and she was a little bit hypotensive. That's why they ordered a transthoracic echocardiogram that had this image on the left. Clearly, we can't see very well what's going on in the heart, especially because of the ventilator. 1 cc of Sonovil just saved the evaluation of left ventricular function on this patient. We could, although it is not optimal, we could clearly see that the left ventricular function is quite normal. This is a study I did with one of my students many years ago in 2005 in intubated patients. We published that on echocardiography, and we looked at the endocardial border definition before ultrasound enhancing agent. We could see that almost 40% of the segments were not seen without contrast, and after contrast, we could see a very significant increase in endocardial border definition in this subset of patients, very difficult patients that are intubated in intensive care. So I would say that it's almost mandatory to use ultrasound enhancing agents in patients that are under mechanical ventilation. This is another case of a 71-year-old male. He's in a 7th day of acute myocardial infarction. The image on the left, we see that there is a possible akinesia in the apex, and there is an image in the apex that we are not certain if it is an artifact or a thrombi. And we injected ultrasound enhancing agents. First of all, we can better see the left ventricular function that appeared actually not bad on the left, but now we see that the left ventricular function is very significantly decreased with an ejection fraction below 30%. And that image corresponds to apical thrombi, as we can see by this negative image at the apex. This is a 55-year-old male, 62 days after anterior myocardial infarction as well. She was at home and came for a clinical evaluation of his myocardial infarction. And this is similarly to that case, has apical akinesia, has an image that also we are not quite sure if it is a thrombi or if it's an artifact. We injected 1 cc of Sonovil on this patient, and we can clearly see that the apex is completely filled. We see also some this black area in the apex that corresponds to the scar area of his myocardial infarction, but clearly he has no thrombi in his apex. So comparing these two cases, one can understand how hard sometimes it is to confirm or not if there is or not a left ventricular thrombi. This is our another case. It's a 51-year-old physician. He had a history of apical cardiomyopathy, father and brother. His functional class was functional class 2. This is his EKG, which clearly shows that he's probably a patient with apical cardiomyopathy as well. And this is his apical two-chamber view. We can clearly see that he's got this obliteration in the mid cavity and has an apical aneurysm. But that's all we can see with that image. Once we use ultrasound enhancing agent, we see that in this apical aneurysm now, actually, there is a very millimetric thrombi. It's a 2 to 3 millimeters thrombi in this apical aneurysm. He was not anticoagulated at the time. So once I finished his echocardiogram, I just gave him his first pill of anticoagulation. So it was quite important for this physician. This is a 32-year-old male, New York Heart Association functional class 3, has a brother with history of sudden cardiac death. This is his transthoracic echocardiogram. Once you see the apex, actually, we can't be sure on the left image if it is an akinesia with a thrombi and a calcified thrombi, or if there is something else. Once you use ultrasound enhancing agents, we can see myocardial perfusion in the whole thickened apex, demonstrating that this patient also has an apical form of cardiomyopathy. hypertrophic cardiomyopathy with a very tiny calcified thrombi in the apex. So actually, in this case, it was quite enlightening because it demonstrated the perfusion in the thickened apical left ventricle of this patient. So we'll talk a little bit about myocardial perfusion at rest. As you know, these microbubbles, just to recall, they have kinetics that are similar to the red blood cells, and they oscillate with at the same frequency as we use for transthoracic ultrasound. And once, because of its high temporal resolution, we can see some defects that are limited to the subendocardium or even transmural defects. So it's quite nice. It helps a lot. And we can also quantify blood volume by the product of the blood pool intensity, the signal peak intensity, to the velocity of microbubble, which is the time that it takes for the complete ultrasound field to replenish with bubbles after destruction. And the blood flow in humans, myocardial blood flow quantification in humans has been validated with echo by this paper with Vogel, where they compare the 30 patients and 15 normal patients. They compared PET, CT, and myocardial blood flow measurement by echocardiography, and the correlation was quite good. This is a 47-year-old male with acute and continuous chest pain, no EKG abnormalities. So this is his transthoracic echocardiogram that is indicated once we have undefined EKG in a patient with chest pain. Actually, we don't see a significant change in wall motion in this patient. When you looked at the four-chamber view, we injected ultrasound-enhancing agents, and that's what we saw. We see a perfusion defect in the apex and clear hypokinesia in the whole lateral and apical wall. So clearly demonstrating that it's a patient with unstable angina. Here again, the two-chamber view with no significant abnormalities. Actually, our eyes are tricked by the trabeculi because once you inject contrast, you take the trabeculi away, and we see that the anterior apical wall is actually not moving and has a transmural defect, demonstrating that this patient actually has a significant case of angina. This is a 52-year-old male, hypertensive, with a continuous chest pain for 1 hour and 45 minutes. This is his transthoracic echocardiogram at ER, and now you see that he has a very severe left ventricular dysfunction, and the black area is consistent with a transmural defect that actually demonstrates together the area at risk and the infarction. By this image, you cannot see what is area at risk and what is actually infarction in this super acute patient, which with obviously occluded artery. We'll talk more about this case soon. Actually, the no reflow phenomenon was first described in 1999 by Dr. Hiroshi Ito, where injecting in an intracoronary fashion, he demonstrated that if you open the coronary artery and there is no reflow, that area will not recover, and these patients will evolve with left ventricular dysfunction. We can also measure the size of infarction using real-time myocardial perfusion echo. This is an experiment we did. This is Paulo Magno, who was the physician in a doctorate program. The image on the right is with an occluded dog LAD coronary artery with a huge perfusion defect and wall motion abnormality. After 3 hours, we reperfused that myocardium, and now we can see the size of infarction because we know that the coronary artery is open and reperfused. So the black area corresponds to the myocardial infarction size which we demonstrated with the pathology specimens in this animal study that we did in 16 dogs here. And this technique has been used by many centers. Maybe the biggest number of patients was performed by Carl Vaitis, is from the group of Professor Sanjeev Kaur, 957 patients. They demonstrated, in summary, that most patients, in a period of 12 hours, after a chest pain, they still exhibit wall motion abnormality, and around 70% of patients, they also demonstrate a perfusion defect with or without wall motion abnormality. Stress echo is a big application since we don't know how the peak images will be. This is a 51-year-old bariatric surgery patient, 500 pounds, has no EKG abnormality, and this is a dopamine echo demonstrating an absolutely normal study in this patient that was just possible because we used myocardial enhancing agents. We did this study very long ago, 2002, 22 years ago, demonstrated the importance of using myocardial enhancing agents in these patients, in patients that undergo stress echocardiography, because especially even with dobutamine or exercise, we don't know exactly how the image will be. So in this case, on the top, you see rest, and in the bottom, peak image, you see that we can see the endocardial border in this dobutamine echo study in the most of the image at peak stress. But once we inject contrast, we can clearly see that the heart is hyperdynamic, and we can be sure that this is a negative study. So it's quite important to use contrast in almost all stress echocardiograms. This is a female, 64-year-old male. She was doing a risk stratification for gallbladder surgery. This is adenosine myocardial perfusion echo. We can see at rest that myocardial perfusion is absolutely normal in the whole myocardium, and at peak adenosine, it is quite normal as well. And this is the quantification of myocardial blood flow on this patient. So this is a pretty normal adenosine. This is a 71-year-old male, hypertensive, diabetic, and dyslipidemic. He had shortness of breath to be evaluated. And this is his adenosine stress. Differently than the last one, we see that perfusion is normal at rest, but at stress, we see a transmural defect in the apex and a very nice subendocardial defect in the inferior septum that's consistent with a very severe LED lesion. We calculated using myocardial perfusion quantification, his myocardial blood flow reserve. Actually, his beta is the velocity reserve. It was 1.6, and the normal values are above 2. Between 2 and 4 would be what we call normal. This is another case, a 74-year-old female, hypertensive and diabetic with a complaint of chest pain. Please note her resting four-chamber view is just, we can't see at all. So the study was lost from the beginning. But once we injected Sonoview on this patient, we could clearly see all endocardial borders and the left ventricular function that was normal. At peak dobutamine stress, we could see myocardial perfusion normal at the apex, but interestingly, there was a subendocardial defect in the inferior basal and mid septum, which was consistent with a 70% lesion in a dominant right coronary artery of this patient. And this is a 66-year-old physician. This is a very interesting case I did a few days ago. He was hypertensive. He wasn't doing an evaluation for chest pain. But then when I was doing his echocardiogram, I saw this in front of the aorta. we see his right coronary artery was not arising from the right spot in the right coronary sinus. It was going around the aorta and going through between the aorta and pulmonary artery, which we suspected to be an anomalous origin of the right coronary artery. And interestingly, that's his CT, also demonstrating that he has a right coronary artery arising from the left coronary sinus and was between the pulmonary artery and the aorta, which was compressed during systole. As you know, coronary blood flow occurs during diastole. So everybody was worried about him. This is a 3D, very beautiful 3D demonstrating the right coronary artery going between the aorta and pulmonary artery that should be in the front. But everybody was worried that he would had ischemia and he would have sudden death. I've done like hundreds of cases in patients with anomalous coronary artery, and the findings are all the same as this one I'm going to show you. This is the left ventricle, the apical views, that's quite normal. And this is the resting image. You see that inferior wall perfusion is quite normal. And this is at peak stress. Note the perfusion is absolutely normal in his inferior wall. He's got 12 minutes in the Bruce protocol, 152 beats per minute, 99% of maximum heart rate, very high blood pressure. So the oxygen consumption was very high and it's quite normal. So I've never seen a right anomalous coronary artery arising from compressed by the aorta and pulmonary artery actually causing ischemia in my life. I've done several cases of those. It's all normal. So when we are dealing with patients with coronary artery disease, this is a paper from Tom Porter's group. Actually, Jeanne Tsutsui was my fellow at the time. She was doing a fellowship together with Tom Porter in Nebraska as part of her program. And she demonstrated that once you have a stress echo with normal wall motion, normal perfusion, the prognosis is quite good. It's similar to normal per pupil. And once the wall motion is normal and only the myocardial perfusion is abnormal, the prognosis is a little worse, but once you have a normal wall motion, it means that the ischemia is of a lesser extent. And once you have both abnormal perfusion and contractility, then you have the worst prognosis on this patient. This is an interesting, it has nothing to do with the cases, but has at the same time. This is actually from Roxy's land, from England, and this is the Proteus study. I just brought it here to show that in a public service, they use in England 75% of all stress echo cases are performed using ultrasound enhancing agents, which I found quite remarkable and state-of-the-art. Congratulations for our friends in England. And then I will show special populations in this next 5 minutes. I know that I'm almost running out of time, but Roxy gave me some minutes, so I'll show these nice cases that I have. This is a 52-year-old female. She lost appetite and weight and had a lot of abdominal and joint pain. This is her transthoracic echocardiogram with these masses that are attached to her endocardium, but please note that the myocardium is contracting quite well. And this is her myocardial enhanced agent study demonstrating that actually the apex is well perfused, but there is a subendocardial abnormal scar tissue with a mass, actually. And this patient had an inflammatory disease called Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. And this is, and to finish, I will just show you my cardiac masses showcase without much introduction. So this is what everybody knows. It's a four-chamber view, a zoomed view of the left atrium with a big myxoma arising from the atrium. I don't know if you can see, but there is some perfusion in this tumor. The next one is also a left atrial mass, but this one is attached to the aorta. So, and you can see here, because of the shadowing, you can see the perfusion, but you can see clearly that it's attached, it's kind of frozen, this part of the atrium and the aorta, it's kind of a frozen structure that is consistent with a metastatic melanoma. It's a malignant case. Another tumor in the left atrium that also has a lot of perfusion, as you see on the right. And this is also consistent, although has a lot of vascularity, it was left atrial myxoma as well. So sometimes it's quite challenging to differentiate a malignant from a benign tumor. And this is also another left atrial mass. This one appears to arise from the pulmonary veins. So this doesn't seem to be glued in the left, in the atrial septum. It's mobile and has a lot of vascularization, and it was a metastatic lung adenocarcinoma going through the left atrial by the pulmonary veins. And this is also another mass on involving all of the right ventricle. And myocardial perfusion studies show that this mass is very large and has a lot of areas of with absence of perfusion, which is consistent with tumor necrosis. And this actually was a metastatic hepatocellular carcinoma. And this is another image that when we saw, we thought we didn't know if it was just an anatomic characteristic of the mitral valve or if it was a cyst. Once we injected microbubbles, we obviously saw that there was no perfusion inside that mass, which consisted of a blood cyst in the mitral valve. And this is another interesting case. It's also a patient of mine. 2000, he had just a thickening of the mitral aortic junction. 2003, a little bit thickening with some mitral valve prolapse. In 2005, this just appeared a nodule in the anterior mitral aortic junction. He had a huge family history of cancer, so we were very worried about that. And this is the myocardial enhancing agent study. So the nodule is just in the posterior aortic wall, and there is a huge acoustic shadowing to the left atrium, demonstrating it is a calcified nodule. Since we did an MRI that also showed this nodule, but couldn't tell exactly what it was because it was isolated in the anterior mitral aortic junction. And this patient ended up going to surgery that ended up demonstrating that it was a calcified necrosis of the mitral annulus that we call a casus degeneration of the anterior mitral annulus, which is very, very rare in this position. We all know this condition in the posterior mitral annulus. As Roxy said, so that changed 35% of the therapeutic, so it's quite important. As an emerging technique, I will just show you this in the next minute. This 52-year-old male with hypertension, lipidemia, and continuous pain. This is the case I showed you before. This is his EKG with ST elevation. And we did a technique called sonothrombolysis on this patient. For at 12 minutes, what we saw was this. Please note that there was a huge wall motion abnormality at baseline and a huge perfusion defect at baseline. And after 12 minutes of sonothrombolysis, which consisted of flashes of mechanical index of 1.3 every 20 seconds, for a period of 50 minutes altogether before and after PCI. So it was 12 minutes before PCI. We could clearly see that the wall motion abnormality was still there, but there was perfusion in the anterior wall, differently than the image on the left, which means that the coronary artery was probably opened. And there was a small area of myocardial infarction in the lateral apical segment. And this was after this, he went to coronary intervention, had a stent implanted in the LAD, and this was the perfusion in his anterior apical wall. And we published this, the first human study in Jack in 100 patients, and we demonstrated that in patients that we called in the therapy group that got sonothrombolysis and PCI, in 50% of cases, in the first coronary injection during PCI, the coronary artery was already open, differently from the control group that they got just primary PCI. Only 20% of the coronary arteries were open, as well as in the reference group that was a group of patients arriving at night. So that's all I have, folks. Thank you very much.
Thank you, Wilson. That was amazing. Great number of cases and excellent examples of how contrast echo, looking at wall motion, perfusion, quantification, how it helped in managing patients. So we've got quite a lot of time, 22 minutes. So we can go through some question and answer. So if you stop sharing, yeah, great, thank you. So let's see what we have. Right. Okay. So we've got only, I can see in the chat question answer, we've got only one question, but we can discuss amongst ourselves regarding what we've shown. But it's a very important statement made by Victor Zelov who's our board of director actually from Ukraine. And we mentioned 60 countries, that we cater to 60 countries where CUS is used, but it's actually 61 because Ukraine has joined us recently. So yes, we agree, Victor. I'm sorry that we've mentioned 60. It is 61, and Ukraine has joined us, and Victor has done an enormous amount of work with contrast enhanced ultrasound, using it in actually in the war fields, which is amazing, and really it is something that Victor, you should share in a bigger forum. So fine. So that. Can't see a chat. Okay. So there's a question saying that can't see a chat. So it's in the question answer. So if you've got questions and answers,
yeah,
there
should be a Q&A button at the bottom of your screen. If you're on a phone or on your laptop or computer, it should pop up there down. There's Q&A, and then you just type in your questions in there, and then we'll be able to see them.
Yeah. Okay, so while questions are being brought up, we can discuss a few things, Wilson, that we have shown. And so in your lab, Wilson, how do you use contrast? Meaning, what is the program in your lab for using contrast echocardiography?
Oh, that's a very good question. Roxy, my hospital is a public hospital in Brazil. So as a public hospital, a tertiary public hospital, we have some limitations. But even with limitations, we have done work with our health ministry, and it was approved. Myocardial enhancing agent is approved for the use and it's paid by the government in Brazil. And every hospital has quotas as we do. We have a quota of around 50 cases per month, which is quite small, close to the size of our echo lab. We perform around 5,000 studies a month. So which is 1%. It's a quite small number, but with that we try to save it to patients where we can clearly see where there is a benefit, especially in stress echo with suboptimal images as the ones that I showed you. And cardiac masses are a big thing, as you also demonstrated. It's of a lot of utility, and we also use it in the cath lab once we are in doubt regarding the presence of left atrial appendage thrombi. Besides all of those applications that I demonstrated and you did, we use in the cath lab as well for left atrial appendage.
Okay, so how do you select your patients? So you just said that you use it in masses. So in other words, how do you decide which patients to give contrast? So, for example, a
Well,
patient comes in, echo was done. Who does the echoes, the sonographers or the doctors?
the doctors here. We don't have
Okay.
the sonographers here. Physicians and fellows.
Mm-hmm.
The ones who decide are the attending physicians. They are the ones that will look at the case, see if they can save the study. And
Mm.
as you may see, patients wait for a long time to get an echo
Yes.
sometimes, and we don't want to send the patients home
Yeah.
without the proper diagnosis. So usually, when the acoustic window is very poor, or it's a stress echo with a moderate to poor window, or if it is a mess, or if there is a doubt on the issue of hypertrophic cardiomyopathy. And we use actually in basically all cases with apical cardiomyopathy with apical aneurysm, because we have seen that there are a lot of thrombies that we don't see using transthoracic echo, especially because, first of all, it's quite difficult to image this fingertip type of aneurysm in the apex on those patients. So, but it's basically at the discretion of the physicians. They know we have restrictions, so our nurse try to keep the team. If they see that the agents will not last, they tell them to really be sure that the patient will get a benefit on that. But in Brazil, just as we have some time, myocardial enhancing agents are approved for every use in cardiology, and it is mandatory for reimbursement in the private and government sector, because it's in a list of procedures that by law all of the insurances they have to pay for the study. So and obviously the problem for us here is the cost. I don't think it's much if you compare with MRI or CT, but it costs around $100. So when you compare that with the price of the transthoracic echo, the providers, they end up complaining a little bit about the price.
Okay, so yeah, so as you said, it's a government hospital and you have a quota, and therefore you are restricted in that way. But the fact that you're showing, right, cases after cases that we have shown, you have shown that by using contrast, you save you save costs. You spend a little bit of
Yes.
money, but you prevent the patient from coming back again to get another test done, or even on the same day you make a diagnosis and therefore prevent the patient from getting another test done as a result of the diagnosis. So now there's quite a lot of data which showed that, right? In fact, the very prominent data is the one published in JACC so many years ago by Bill Zogby's team. I mean, that is very clear that you change the diagnosis, you change the way you investigate the patient, and therefore cut cost, right? So
Yeah.
if you show this to your hospital, will they not say, okay, why don't you use more? Because that will prevent the patient from having another test done. In fact, in my hospital, that's exactly what we've done. So in my hospital, we can use as much contrast as we like because they've seen the benefit of it. They've seen, for example, even I've shown you an example where the patient comes in following the theater. After the theater, the patient came in and we demonstrated there's a hematoma. So they see the usefulness of the technique where the patient can be acted on very quickly. Otherwise, it would have taken time for them to come to a diagnosis, and the patient may have been lost just waiting for a diagnosis to happen. So in our lab, we have a system where, like yours, that no patients go back without having a contrast done if it is indicated. And in our practice, in 10% of our resting echo patients, we do contrast. 10%, which is, I think it's pretty good. And in stress echo, of course, we use it in nearly 100% of cases in my hospital because again we know that we cannot afford to miss even one segment. And remember, when we give dobutamine, when we do exercise, we tend to lose segments if we don't give contrast. And in the days where we don't want to miss a disease, uh, we want to give the full benefit to the patient by giving contrast. And so in UK, we are using contrast much more liberally. I mean, we also work in an NHS hospital.
Yeah. I know that your management system is quite wise and smart because it's a localized management, and
Yeah.
then you can decide what's good or not and where you are going to put your money. The problem is the if to work for the hospital administrators, they would tell me the same thing, using everybody. They know the value of it.
Yeah.
The
Yeah.
problem is that we have to negotiate with the Brazilian government because it's a federal government budget that comes directly
Yes.
to the hospital. So it's a quite complicated negotiation.
Yeah.
But we evolved a lot in the past 10 years. In the old days when we produced PESDA here, the
Yeah.
the agent that Tom Porter invented. And in those days, we use it for everybody because we
Yeah.
just
Yeah.
had a myocardial bubble factory here. But once the industry and all of the regulations for clinical use, not research,
Yeah.
use came in, we cannot do the PESDA, manufactured PESDA bubble anymore. So
Yeah.
we still have some challenges, I
Yeah.
think. But
I think the audience who has kindly participated in this meeting and they saw this case. I think one thing that stood out is the fact that as you mentioned, apical hypertrophic cardiomyopathy uh, is a condition where we can make a diagnosis just looking at an ECG, right? And we can do
yeah,
an echo and can suspect that it's apical hypertrophic cardiomyopathy. But what is new now is the fact that detecting apical aneurysm is very important because it has prognostic value. Now it is used in the sudden cardiac death risk factor, the presence of apical aneurysm, and that
yeah,
we easily miss with echocardiography. We can make a diagnosis of apical hypertrophy, but we we almost always miss a diagnosis of apical aneurysm. So I think it is mandatory to give contrast in all patients with apical hypertrophic cardiomyopathy. If you don't see an aneurysm, you give contrast to show, to conclusively show that there's no aneurysm, and then let the patient go. And that's what we do now. We've got a big cardiomyopathy unit. Now, they've essentially, the cardiomyopathy group has agreed for us to actually give contrast in all patients with apical hypertrophic cardiomyopathy coming to the diagnosis which has been made for the first time. You give contrast.
Yeah, actually, this is a particular group of patients where we should give to all patients with suspicion of hypertrophic apical, especially apical
Yeah,
hypertrophic cardiomyopathy. I've seen a lot of patients with the thickness in the gray zone between 12 and 15 millimeters. And myocardial contrast agents, they are crucial to make the proper measurement of the thickness of the apical wall in those
yeah,
patients where the thickness is not so robust. And
yeah.
I've seen that in several family members of patients with hypertrophic cardiomyopathy, especially the apical form. So I think that once you use myocardial enhancing agents, you make your measurements of thickness closer to the measurements of the ones they get at MRI. So
Yes. Yeah, absolutely. Because, we can look at compacted myocardium, which we cannot without contrast. We pick up trabeculae and call that a muscle mass, and make
yeah,
mistakes. I mean, there's so many mistakes made where the trabeculae were picked up and a diagnosis of apical hypertrophic cardiomyopathy was made on the basis of that. And then when you gave contrast, you find that it's all trabeculae. It's not a muscle. So either way, I think contrast is very important to establish a diagnosis of apical cardiomyopathy, hypertrophic cardiomyopathy, and exclude it. Yeah. So, so moving forward, Wilson, the cases that we have shown, right? So what we have really shown is the value of using contrast to look at masses, right? And make a diagnosis
yeah,
of a mass. Because we can actually establish a diagnosis of a mass by giving contrast. Like with MRI, they look at the characteristic of that mass and say whether it's a thrombus or a tumor. Similarly, we can do it with contrast. So if it's vascular, it's highly likely it is malignant. And if it is avascular, but with no wall motion abnormality around it, it is still a tumor, right? But if there's a wall
yeah,
motion abnormality, akinetic areas with the mass, it's likely to be a thrombus, but it should be avascular. So it does give us a lot of, you know, um, uh, that echocardiography now can make a diagnosis of the characteristic of a mass and come to a diagnosis looking at the characteristic of the mass in terms of vascularity. So this is a very important use of contrast echo. And
yeah,
and even even in vascular cases where I have shown one case of how we nearly saved the patient from having a biopsy done because even on CT they thought it was a mass and an inflammatory mass, give some antibiotics, but it looks necrotic, do a biopsy, and how contrast has saved the situation. I mean, you can clearly see, the where the contrast is going, and you can make a diagnosis of aneurysm, etc., and even dissection if required, even dissection if it's not very clear. So I think for vascular cases, I think it's used more and more, in looking at communication conduits in adult congenital heart disease. It's, people are beginning to use contrast much more.
Yeah, and also just to remind patients with acute coronary syndromes, I didn't show here, but we had a couple cases where we saw that myocardial rupture was about to occur because we saw some bubbles going through the pericardium through the infarction area. So I think that looking at the complications of myocardial infarction, especially pseudoaneurysm and myocardial rupture, is quite important,
Yeah.
especially in those patients between the
Yes.
third and the seventh day of acute MI.
Correct. Correct. Yeah, and of course, I mean that's the amazing utility of perfusion at rest with patients coming in with chest pain, where actually you can wait if there's good perfusion everywhere. You don't need to jump and call the cath lab to open up an artery because it's already perfused. So
Yeah.
you can wait and do it the next day or maybe 2 days after. So, it does help to risk stratify the patient and therefore decide whether you need to act straight away or you can wait. I think perfusion component is very important in patients coming in with chest pain.
Yeah, it's, especially if you look at the physiopathology, if you are doing the study while in chest pain, you
Yes,
can exclude completely the presence of acute coronary disease in these patients in case there is no perfusion defect.
with chest
Actually,
pain,
in
yes.
case there is, yeah, in case there is no significant perfusion defect. Because I don't know in your experience, Roxy, but I see chest pain mostly in patients with transmural defects, with large area of wall
Mm,
motion abnormalities usually. I've never seen a patient with chest pain just having a small subendocardial defect.
yeah,
So
yeah,
usually
that's correct.
transmural.
That's correct. Thank you.
Thank you. Bye bye.